Hi, this is Brian Kim. I'm going to share with you case number 23 in the best way to do cataract surgery series. This is a dense lens, about 3+ dense lens, a small pupil. I'm going to show you how to disassemble this lens using double chop, cross chop, and mechanical fracturing forces. No need for pupil expanders, no need for iris hooks. Pulling the lens pieces up with the chopper, not going after pieces with the phaco tip. I see too many very good surgeons trying to grab pieces with the phaco tip, and they go back into the capsular bag. They have trouble pulling the pieces out of the bag. They're scared to go out with the chopper, and so they're kind of stuck. And that's why they have to use a ring or hooks. And I'm going to show you very clearly that you do not need these devices in order to do a very successful and efficient cataract surgery. So I'm using my corneal marker to help me center and size my rhexis. I make my superior and inferior paracenteses incisions. I use a cotton tip to help me turn the eye, and then I make my incision, making sure I'm flat and parallel to the iris plane. You need a really nice corneal shelf so you get a good self-sealing corneal incision. I'm injecting intracameral lidocaine and epinephrine, and I'm going around circumferentially, injecting on the surface of the iris as well as underneath the iris. You can see the iris is responding to the medication. I'm injecting dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. I'm going to do my triplanar corneal incision using my cannula to hold the eye and make a vertical groove, and then place the blade into the groove and go deep, and then tunnel through the sclera, and then heal up, and then I enter in, making my triplanar corneal incision. I do my puncture style capsulorhexis using my forceps. I puncture and then pull down towards my main incision, and then I sweep a little bit to the right. I create a small flap and grab that flap, and then I go around circumferentially, making sure I don't have too much viscoelastic egress, and I try to follow the contour of my capsulorhexis with the previous corneal markings that I made. You can see I grab and re-grab. In this case, because the pupil is smaller, it's a little bit easier to make my rhexis. At the end of the rhexis, I burp some viscoelastic from the wound to decompress the eye. And then I'm going to do my capsular fornix hydrodissection technique. I'm going to place the cannula out to the equator, contra-incisionally, point the tip down. I get a nice fluid wave that propagates, and then I'm going to decompress to the left side, and then I'm going to spin the lens to the right side using the right angle cannula. You can see the lens spins quite nicely after this maneuver. I'm going to go into the eye with irrigation off. I'm going to lift the incision with the chopper and then go in with the phaco, again with irrigation off to minimize Descemet's trauma. I'm going to remove the surface epinuclear material here, and I'm going to place the chopper flat underneath the epinuclear ridge out to the capsular fornix. I'm going to rotate the phaco tip vertically, subincisionally, and I'm going to grab on both ends of the lens with the chopper and the phaco tip, pull the instruments together towards the center, and it fractures the lens completely in half. And so this is the double chop maneuver. I'm going to place the chopper out underneath the anterocapsular rim across the right heminucleus, and then pull it towards the center, and I crush it against the phaco tip, which is in the middle, and this is the cross chop maneuver, dividing the right heminucleus. Now at this point, I have 3 separate pieces. I chose to grasp the first quadrant with the phaco using some vacuum, and then I crush the lens piece between the chopper and the phaco tip. Again, I use that vacuum to really kind of help manipulate the lens piece in front of me. This will help me maximize being able to crush the lens and sandwich it between the chopper and the phaco tip. So again, I like to use crushing forces, trying to break the pieces into smaller pieces using high vacuum as well as pulses of ultrasonic energy. Now I'm going after the second quadrant. I'm placing the chopper out to the equator underneath the anterior capsular rim. I pull the chopper centrally towards the phaco tip, and it crushes the second quadrant into 2 pieces. I pull one of the pieces up out of the bag, and I start crushing the lens piece. Again, I'm just using fluidics to grab the lens piece. I'm kind of manipulating the instruments so that the lens is going to be between the 2 instruments, and I crush the lens piece between the chopper and the phaco tip, and then I use ultrasonic energy as well as high vacuum to remove the lens pieces. So this is the last piece of that second quadrant. I'm just going to pull it up out of the bag, and then I start crushing it and sandwiching it between the chopper and the phaco tip. You can see this is a very slow, methodical, and controlled manner in which I'm doing this. The chamber is completely stable, and I'm using minimal ultrasonic energy. So I rotate that last heminucleus in front of me. I place the chopper out to the equator, and then I'm placing the phaco tip deep in the bag to make sure I'm able to maximally crush the entire girth of the lens. And when I do this, you can see I get a nice separation. I do some lateral separation, and now I have divided that second heminucleus. I'm going after that third quadrant, placing the chopper out to the equator, and then pulling the chopper centrally, and I'm able to crush that third quadrant into two pieces. I'm going to use a little bit of vacuum to pull that piece out of the bag, and then I'm crushing that lens pieces between the chopper and the phaco tip, making them into smaller bite-sized pieces. Again, using bursts of ultrasonic energy as well as high vacuum to emulsify the lens pieces. You can see I'm using limited ultrasonic energy because whenever I'm able to remove the lens pieces with a high vacuum, I rather use vacuum instead of the ultrasonic energy to remove the lens pieces. So you can see very carefully and methodically, I'm crushing the lens pieces, breaking the pieces into smaller pieces, and using that high vacuum to remove the pieces. So this is the last quadrant. I'm placing the chopper out to the equator. I'm placing the phaco tip deep, and then I'm able to crush the girth of the lens piece completely. I'm going after each separate piece now, crushing those pieces into smaller bite-sized pieces, and again, using high vacuum and intermittent bursts of ultrasonic energy in doing so. So this is the last piece now. I'm crushing the lens pieces. I grasped it with the vacuum and then crushed it between the chopper and the phaco tip using mechanical fracturing forces. And now all of the lens is gone, and I'm removing the epinuclear material. I want to make sure that the chopper is deep to the phaco tip as I very carefully and using foot pedal modulation, removing the epinuclear shell. I take the chopper out and then push BSS. When I push BSS, I take the phaco tip out and then switch it with the INA handpiece. Again, this is to maintain some level of chamber stability as I switch my instruments. I start my INA and I start subincisionally first. The polymer tip makes this a very easy and safe procedure. I'm just going around circumferentially, removing the cortical material. I'm going underneath the anterior capsular rexus edge here. When I'm dealing with smaller pupils, I like to switch fairly early to the polish mode because when there's small pupils, I worry that this could be due to zonulopathy, and I don't want to use high vacuum when I'm doing the IA. I might grab the anterior capsule edge, and this might cause some zonular stress. So you can see the back is fairly clean. I'm pushing BSS into subincisional capsular fornix, and in this case, there was not much cortical material left. I'm injecting cohesive viscoelastic into the capsular bag, and I'm polishing underneath the anterior capsular rim, first on the left side and then on the right side. And you can see this is a fairly clean bag. I'm trying to be very gentle, trying not to touch the iris too much with these maneuvers. Again, with dense lenses, and especially with smaller pupils, I like to use a 3-piece lens instead of a 1-piece lens for more capsular fornix support. And so I use my diamond blade to widen the incision for this injector. And then I'm injecting the 3-piece lens. In order to have the haptic come out flat in the left side, I turn the bevel to the left. As the lens is delivered, I rotate the barrel 90 degrees counterclockwise, and the optic comes out flat, and then I come out with the injector. I'm using the Maltzman to make sure that leading haptic is indeed in the bag, and then I'm using the Maltzman to dial in that trailing haptic, try to make sure I don't catch the iris as I do this, and I'm able to dilate that trailing haptic and ensuring that it's in the bag. I'm going to use my INA with irrigation off. I go in, and then I'm going to go underneath the lens, making sure both haptics are still in the bag, and I'm going to tilt that lens to make sure I get underneath it and remove all the viscoelastic from within the bag. And then I'm removing the viscoelastic from the anterior chamber. I'm pushing BSS through my paracentesis, come out with the INA. I'm going to quickly withdraw the cannula and then hydrate my incisions just to help maintain the anterior chamber. So as you can see, this was a fairly dense cataract with a borderline pupil. Some surgeons, out of habit, go after the lens with the phaco tip, and if the lens is stuck, it will just withdraw back into the bag and the surgeon will get frustrated. If you get frustrated, you might end up doing something that you shouldn't do and you might cause a complication. There is absolutely no reason to do this. You don't need pupil expansion devices. As long as you know how to maneuver a chopper within the capsular bag and perform double chop, cross chop, and mechanical fracturing, you can have a very easy and routine cataract surgery with the borderline pupil and the dense lens. So I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.